Hello, everyone. A very warm welcome to day three of PHARMASTEER 2023. This pioneer virtual orientation program, which is organized by Department of Pharmacology and Therapeutics at GS Medical College and KEM Hospital, Mumbai, in collaboration with AstraZeneca Pharma India Limited, is receiving great accolades this year as well due to its extremely successful day one and day two. I, Ashish Kumar Dubey, Manager Medical Excellence, AstraZeneca, would like to welcome you all once again. We do have extremely exciting agenda for the day today, and without any further ado, let us dive into our first session of the day, and which is role of pharmaceutical industry in addressing public health challenges and academician's perspective. And for that, we have with us Dr. Gauravi Mishra. Dr. Gauravi is a professor and physician, Department of Preventive Oncology, Center for Cancer Epidemiology, Tata Memorial Center. Dr. Gauravi is a distinguished professor and physician at the Department of Preventive Oncology, Center for Cancer Epidemiology, Tata Memorial Center, with a wealth of experience spanning over 2 decades. Dr. Gauravi is a dedicated researcher and PhD guide, contributing significantly to cancer epidemiology. Driven by passion for public health, she has spearheaded numerous initiatives, received 22 awards, and actively engaged in capacity for building national cancer control programs. As a seasoned clinical trial investigator, prolific author, and esteemed reviewer, Dr. Mishra continues to make impactful strides in the field of preventive oncology. With that, please join me in welcoming Dr. Gauravi onto the stage. Ma'am, over to you.
Thank you, Dr. Ashish, for that wonderful introduction. And at the outset, I would like my sincere thanks to Dr. Sandhya Kamath, Dr. Rakit Tripathi, and all the organizers, including AstraZeneca, for inviting me for this webinar. And it really gave me an insight into what's happening into pharma industry, and this is a very different topic that I myself am presenting, and I'm very excited to share my experiences. So I will. Is my screen visible?
Yes, ma'am, it is.
Yeah, and I'm audible, right?
Yes.
Yeah. So thank you all, and we are going to speak on a very different aspect today. I'm a public health person, and I've my 2 decades of experience actually has been in preventive oncology. I'm working at the Tata Memorial Center. So I'm going to share some of the experiences, my personal experiences regarding how pharma industry actually contributed to advancing public health in oncology, and also some of the experiences that I learned globally that are happening with relation to pharmacological industry. So my topic is about sharing the role of pharmaceutical industry. I mean, are they part really in addressing public health challenges? And these are my perspectives based on our experiences. At the beginning, I would like to declare that I have absolutely no conflict of interest, and maybe that I'm referring to some pharmaceutical industries more often during my presentation, but this absolutely has nothing to do with a particular pharma or something. I have no conflict of interest whatsoever. So let me begin with by saying that we all are very aware about the pharmaceutical industry's role in developing new drugs and formulating, developing, and bringing life-saving, efficacious medicines to the market, and hence promoting good health of the mankind. Though this is the key role that has been really recognized by everyone, there are several other roles that the industry performs. And I think that the pharmaceutical industry's contribution to public health arena are really varied and widespread, right from donating medicines, providing funding for so many health initiatives, helping in pandemic planning and responding appropriately to pandemics and crisis situations, and also providing education both to the healthcare personnel, to the normal general people, to patients, etc. So they have a wide range of activities to perform, and these are the commonly recognized roles of the pharma industry, but I will be focusing on the role of pharma industry in terms of addressing public health challenges. Indian pharmaceutical industry, you all are very well aware, it's the world's largest by volume and 14th largest in terms of value. The annual turnover is over 3 lakh crores, as was reported during 2019-20. And we are well known for the vaccine production. So India accounts for nearly 60% of the global vaccine production, and it is very well recognized for the low-cost vaccines globally. Now, to cite the first example of our contribution, the pharmaceutical industry's contribution to public health, I would like to talk about the polio eradication drive. Now, this is something that the WHO is working over in collaboration with so many NGOs and the UNICEF. We have been putting all our efforts to see that polio should be eradicated through the world. And this would not have been possible without full support from the pharma industry. India saw the last case of polio in 2011, and for the last 12 years, we have not reported a single case. And this journey, and we are on the verge on polio eradication globally. So this was the Global Polio Eradication Initiative that was formed by the World Health Assembly in 1998. And it has partners, including the CDC and other partners that are working so that every child receives several doses of polio vaccine. And they hold an annual meeting or an annual event yearly, wherein there's a consultation between the Global Polio Eradication Initiative. There are people from the national authorities for containment, and there are leaders from the national regulatory authorities. And in this annual event, it is decided that what is going to be the future plan, and how are we going to optimally plan for the production of the vaccine over the eradication strategy, how much vaccine would be required. All this planning takes place in collaboration with the public health people. So I think this is a very great initiative and a great support from the pharmaceutical industry, wherein they work closely with the global leaders for a public cause. This was one of the examples that I wanted to cite. And we'll look at several vaccine initiatives in the beginning. So we know that, as we discussed, that India really contributes to a large volume of global vaccine production. India actually contributes to 40 to 70% of the WHO's need for DPT and BCG vaccines. And it delivers around 90% of the WHO's demand for measles vaccine. So we are well known for the vaccination drive. And if we remember the COVID vaccine development, I think the entire world and throughout India also, everyone, even the general public, they were absolutely looking at the newspapers and the media to find out, where is our vaccine development phase, where have we reached, when the vaccine would be launched in the market, and everyone was following up with the news. So COVID-19 pandemic and the vaccine development, it really underpins the pharmaceutical industry's critical role in the global health security. There have been significant contributions. In particular, we saw a rapid vaccine development and deployment of vaccine to various regions during the pandemic. In the post-COVID-19 pandemic period, surely the public opinion about the pharmaceutical industry changed. And this has opened new opportunities to collaborate and work together in building resilient health systems. What role did pharma industry play during the COVID-19 pandemic? As we are aware that during the pandemic time, the pharma industry and public health community, they were knee deep in terms of preparedness, in terms of pandemic planning, and the public health community was seeking out to pharma industry for producing vaccines, for really having drugs in place such as Tamiflu, and at the same time, pharma industry was also collaborating a lot with the public health community in order to get a better sense of what the guidelines would be, what the recommendations would be around the treatment, so that they would also be ready with the production in appropriate times. And this, we saw that this ensured an efficient supply of all the essential medicines to all partner countries, with a quick turnaround time in manufacturing all the repurposed drugs also like remdesivir, hydrochloroxychloroquine, and also favipiravir. So this was only possible because the pharma industry was working very closely with the public health community, with the policy makers, with the decision makers in terms of the guidelines and the recommendations. And surely the pharma industry also invested very heavily into research and development for screening, treatment, prevention during the COVID-19 time. And they launched quickly testing kits into the market and the vaccines into the market. So this is the role that they played during pandemic. Going to the little bit of past history of how the pharma industry has worked with the vaccine. So addressing the public health challenges. So in Africa, in sub-Saharan Africa, even till 2002, it was realized that only 50% of the children actually receive the basic vaccination during the first year of their life. And this was reported by the WHO, UNICEF, the World Bank, etc. And we know that African continent bears the highest per capita burden of the vaccine preventable diseases. So the Merck Vaccine Network, this was launched in Africa during 2003, and it was a multi-year initiative to help increase the capacity of immunization programs and effectively deliver the vaccines, especially in Kenya, in Mali, in Uganda, and Zambia. So what they did in this network was that they collaborated with the government agencies and conducted a lot of training for the national and regional healthcare workers in vaccine management and immunization services. So this was two-way learning, wherein there was a program manager from the African country, and there was one more program manager from an institute based in either US or in Europe. And this was the train-the-trainer approach, wherein the senior managers were trained and then they passed on the knowledge, skills, and the confidence to the junior project managers and the immunization team. So this is what has been going on out along with the pharma industry, and increasing the vaccine coverage with this collaboration has a big public health impact. I will share our own experience with the HPV vaccine trial. So HPV vaccine trial, my Department of Preventive Oncology and myself, we were involved in HPV vaccine trial, all vaccine trials, in fact, with the GSK-led phase 2 trial, and then we were involved in this Gardasil vaccine trial, and also with the serum vaccine trial. But I'll share this experience with the Gardasil vaccine trial. So this was a trial wherein a cluster randomized trial wherein we had chosen 10 sites in India. This was an IR-led trial, so International Agency of Research in Cancer, which is based in Lyon, France. And the running of the trial, the management of the trial was to be funded by the Bill and Melinda Gates Foundation. But Merck played a very important role in donating the vaccine, because we were looking there when the vaccine was launched in 2006, it was a 3-dose vaccine. And actually, we wanted to see whether 2-dose vaccines would work as equally good as the 3-dose vaccine. And herein, if we can understand, no pharmaceutical industry would actually like to reduce the number of doses, because that then decreases their sales and their profits. But Merck readily agreed to donate the vaccine, but at the same time, they had no role in the design of the trial or in protocol development or in any aspect of study of the conduct of the trial or analysis of the data. So the MOU was signed with the WHO for this particular trial. And this was a multi-centric trial, so you can understand the challenges of conducting a multi-centric trial, that every center had the IC approval, which was received, few months earlier or later. But we started this trial, initiated in September 2009, and we were recruiting the girls, and every center was at different phases of implementation. Some had completed 1 dose, some 2 dose, some were still recruiting. And suddenly in April 2010, that is just few months after we had initiated the trial, on 8th of April 2010, there were a lot of reports in the newspaper saying that some other site, not related to our trial, some tribal girls, they had died, and this may have been related to the vaccine. And on the same day, ICMR passed a notice that no one could conduct HPV vaccine trial in the country, though the vaccine was freely available in the market. Then later on, it was investigated, and it was found that the deaths were not related to the vaccine, but there was a 10 months gap period during which all the vaccine trials were stopped. So then inadvertently, I mean, that was absolutely not the purpose of the trial, but then we had some girls after when we started at 10 months, after 10 months, who had received only one dose and they were not traceable. Some who received 2 doses at 2 months interval, some who had received 2 doses at more than 6 months interval, and some who had received 3 doses. So we had this experimental design which was absolutely unintended, and thankfully Merck still continued to supply the vaccine free of cost, and we continued with the trial. And this was a trial that actually gave the result that 2 dose vaccines work as equally as 3 dose vaccine. In fact, when we continued with the longer follow-up for these girls, we are the first ones to give evidence that even a single dose vaccine would work. And WHO has already given recommendations for 2 dose vaccine, and it has already strongly supported a single dose vaccine also. And the future trials that are being conducted elsewhere will give a stronger evidence of the same. So this was again possible because of the vaccine that was the donation that was continued through the Merck, though not interfering in the trial aspects in any form. There are partnerships which are possible between the public health community and pharma industry, and they may have vested interests. For example, as a public health person, we are really interested in seeing to it that the treatment, the drugs, they reach the remotest of the villages, and everyone has access to the care and coverage, including underserved population and children. And at the same time, pharma industry is also very keen to ensure that their medicines, they reach everyone, and everyone has access to the medicines and the latest of the therapies. So there is a vested interest, but it's a win-win situation for both. I will, a lot of the pharmaceutical industries, they have their own foundations, and they work through the CSR funds being donated through the foundations. And some of them are doing good programs in terms of access to treatment in remote places, in a lot of African countries, in villages, and even in some of the places in the Western countries where the treatment actually doesn't reach. So the aim of this cancer access program was to see that to improve the patient's access to quality and equitable care, cancer care in the underserved communities, and to improve community awareness in such a way that the myths, misconceptions, and stigmas would be tackled, and they use digital media to enlighten the community, to create awareness amongst the community regarding the same. Several examples wherein chronic diseases problems like malaria in African countries, and the pharma industry has joined hands with the government and with the public health community to tackle such issues. Now, Pfizer has a partnership in the African countries to in Ghana, Kenya, and Senegal. They have been doing this program since 2007 to help close the critical gaps in malaria treatment and education. And they develop and support pilot efforts to engage and educate the treatment providers also and the patients to use effectively the malaria treatment, and also to have the patient adherence. So the entire aim is to reduce the rate of malaria morbidity and mortality by improving the patient symptom recognition, treatment, and referral. And this is achieved through a lot of training to the healthcare providers and also to the patients, so that they adhere to the treatment and they complete the necessary treatment. And this is all achieved through community mobilization. And Pfizer also has something like global health fellows who work very closely with the community. So they have their own Pfizer colleagues who go on assignments of 3 to 6 months to work with different non-governmental organizations, with multilateral organizations, to address the common issues like HIV/AIDS, tuberculosis, malaria, and other devastating diseases in the developing countries. They work with them, they identify the issues, and they try to join hands with the public health community there in order to improve the health of the population there. GlaxoSmithKline also has an African Malarian partnership wherein they are very closely working in sub-Saharan Africa with the NGOs over there, not only with the treatment, but also encouraging preventive measures like encouraging the community to use bed nets for indoor residual spraying and prompt anti-malarial treatment if diagnosed with malaria. Now, different types of public health programs that people are doing. For example, GSK has this very interesting program which is known as PHASE, that is Personal Hygiene and Sanitation Education, wherein what they're doing is they go to a lot of developing countries in Africa, Asia, and they have adopted certain schools over there, and they educate the children about the importance of hand washing after using the latrine, and they also educate the communities on the importance of having well-maintained latrines. So as a result, you can actually see the impact, and the impact is in the form of children being less absent from the school because now they suffer less from diarrheal diseases, and hence the school grades have improved, and they are better educated. So small measures, small community activities can have really large impact on the community. Yeah. So then again, lymphatic filariasis. We are looking at elimination of lymphatic filariasis globally. And for this, there's a global alliance to eliminate lymphatic filariasis, and wherein there are a lot of partners, including WHO, national government, NGOs, the donors, the academicians, and Pharma is one of the partner over here, wherein the entire objective is to interrupt the transmission and control the morbidity due to lymphatic filariasis. So this is a 20-year program to break the transmission cycle. And herein, this is very interesting because there are so many different pharmaceutical industries who have joined hands together to work for the same cause. For example, GSK has committed, it is already donating albendazole, and it has committed to donating as much albendazole as needed to the WHO each year until lymphatic filariasis is eliminated globally. Similarly, ISI has been donating diethyl carbamazine tablets, and they have also committed to continue donating it till it is eliminated as a public health problem globally. MSD has been continuing to donate its treatment to the developing world. So again, with all this, we can see the impact wherein 14 countries, they are now acknowledged as being achieved elimination of lymphatic filariasis as public health problem, and there are several more countries which will be soon declared as being free from lymphatic filariasis. So this is again a very big public health initiative where different pharmaceutical companies have joined health together. The Merck Baptism Donation Program, again herein Merck has been working very closely with the WHO and with the public health community for the treatment of onchocerciasis, that is liver blindness, and they have committed to supply the medicine and work towards prevention of lymphatic filariasis as well, along with onchocerciasis, because they have realized that this at many places it actually coexists. And this program has reaches to more than 100 million people each year. I think another important role that a pharma industry plays is capacity building. Again, two top public health issues that face life science industry as a professional healthcare education and also access to medicine. So pharma industry, they develop and they produce and they come up with new treatments with dramatic results. But then the emerging nations may not be aware of this treatment. There are so many places wherein the physicians, wherein the healthcare personnel may not be aware of what's going on and what are the newer developments that are happening. So to address this need, by providing educational opportunities and training of the physicians and other healthcare workers, this is what the pharmaceutical industry are playing a big role in this particular area. So they not only support in terms of educating the physicians with the newer developments and also with the continuing medical CME programs in terms of improving the adherence to national guidelines and evidence-based practices. They help to change physicians' behavior, again, which is a very crucial step to tackling the inefficiencies of the system. But they also have a big role in patient education, wherein they actually they educate the people, and especially in chronic disease conditions like diabetes, a lot of patient education is required in terms of changing their lifestyle behavior and also in terms of adhering to treatment. And then they run a lot of public awareness campaigns also for diseases like HIV, malaria, tuberculosis, not only in terms of change of behavior, but also in terms of reduction of stigma that is associated with these diseases. In terms of training, a lot of examples are there, but we know that Africa, has the largest number of refugee population, and Merck had joined hands to introduce these nursing libraries, wherein specific issues dealing with healthcare of the refugees and how to deal with it, that knowledge was provided to the nurses, and the libraries were set up at the latest nursing, containing the latest nursing health information, providing the training so as to better meet the refugee health needs. Now, this is one example that I would cite from Tata Memorial Hospital. We have this KVAT program. So KVATs are patient navigators, and this is the only training program for patient navigation for oncology in India. Wherein the KVATs or the patient navigators, they handhold the cancer patients and help them to navigate in the entire continuum of care of cancer, right from prevention to diagnosis to treatment and survival. This is a 1 year course, and then followed by 1 year of internship, and we take around 40 candidates per year. And then, of course, the trainees are after completing, they are placed in different hospitals. So in this program, Cipla Foundation has joined hands, and they sponsor 10 candidates every year for the KVAT navigation program. And not just that they sponsor, they have also sponsored around 26 candidates for the KVAT assistant programs. And they have also recruited some of the candidates who have passed out into their palliative care center at Pune. And we know that Cipla Foundation also has a very good palliative care center at Pune, and which meets a public health requirement and demand for the palliative care services in the country. And currently, they are also enrolling TB patients in the palliative care center. So Cipla Foundation also runs a program wherein the mobile healthcare units through HelpAge India are run through the rural communities, and they provide high quality primary healthcare services to the patients in remote locations. So this is a very good public health initiative which is taken by the Cipla Foundation. If you look at the role of Cipla in public-private partnership towards tobacco control and cessation, even WHO recognized them as a leading partner in prevention of NCDs, and they're closely working with the government stakeholders towards community outreach interventions, especially in the states of Goa, Madhya Pradesh, and Karnataka. They have helped in initiating and starting the tobacco cessation clinics at the primary healthcare centers in the states, and they have trained the doctors and paramedical staff in tobacco cessation and tobacco control interventions, and also in the counseling skills. In addition, of course, they are also donating their Nicotex, which is the nicotine gum for the nicotine replacement therapy, to assist in tobacco cessation. So herein we can see that there is a public-private partnership where the pharma industry is closely working with the government. Now, again, sharing experience from Tata Memorial Hospital, we had this Africa Asia Luminary meeting, which was conducted by the Merck Foundation. This was a 10th event that was conducted this time at Tata Memorial Hospital 2 months back in October. And I was part of this program wherein there were around 100, 150 people who participated directly, physically. They were brought in from different African and Asian countries, and they were participants in this program. And in addition, this was also a virtual event. So more than 10,000 participants, including healthcare providers, policymakers, researchers, academic people, media representatives from nearly 70 countries participated in this particular event. And you can see the names of the countries that participated. And this was done to expand their professional capabilities in healthcare research and media, and build their capacity in terms of cancer prevention and early detection. They have earlier also sponsored candidates from African countries for their scholarship program in oncology training. And with this, there are doctors from 37 African countries who have been trained, and many of them are actually the first oncologists in their particular country. So a big contribution for the pharma industry in setting up the oncology, initiating oncology services in these countries. Sharing some other experiences with respect to chronic diseases management and how the government reaches out to pharmaceutical industries for addressing the public health challenge. In China in 1990s, the government realized that less than 20% of the people with diabetes actually knew that they had the disease before developing any complication. And with this, the government approached the pharma industry in order to get their practitioners educated in how to recognize the early signs and symptoms and for appropriate management of the diabetic patients. And this was the trainer program. Again, herein various pharmaceutical industries joined hands together to work for the same cause. And GSK also helped by donating medicines for short-term treatments to organizations such as HOPE. And GSK also contributes in terms of providing HIV and malaria medicines at cost for at least 64 least developed countries and to the governments and non-profit organizations. So there is can pharma industry also have a common research agenda? That is what we need to understand. So with the public health partners, so research and development of new products that impact lifestyle, it continues. And for instance, obesity drugs. There are many goals that are shared very commonly by the industry and the public health community. Like the public health community also wants to tackle this issue of obesity, and the pharma industry is also trying to develop some drugs. So if we could combine forces to come up with a research agenda to address such needs, whether those interventions are really having an impact on public health, that is, I think, a great opportunity of partnership between public health and the pharma industry to develop a common research agenda, to have a common research protocol, wherein the needs of the public health community are addressed in collaboration with the pharma industry. There have been a lot of partnerships in terms of working towards the control of HIV/AIDS. One such partnership with the government of Romania, wherein the Merck Foundation it worked to increase the access to treatment and care for children with and adults with HIV/AIDS. There is another example from Africa, wherein the African Comprehensive HIV/AIDS partnerships, wherein the Merck Foundation, the Bill and Melinda Gates Foundation, and Merck, they closed very closely with the Botswana government and to address the national response to HIV/AIDS through a very comprehensive approach to prevention, care, treatment, and support. Again, we have example from China, wherein they worked very closely, MSD worked very closely with the Chinese government, not only for support, treatment, care, but also to deal with issues related to stigma of HIV. And then we know about Merck, about Pfizer, recognizing that two important fungal infections for the AIDS patient, the cryptococcal meningitis and esophageal candidiasis, online training modules were set up to support diagnosis and treatment of these conditions, and they also provided diflucan, an antifungal agent, to treat these two conditions associated with AIDS free of charge to the government and NGOs in the developing countries. Uh, Again, the HIV/AIDS partnership in the southern US, wherein there are so many diverse, ethnically diverse communities in urban and rural areas, wherein the treatment was not really accessible, and the funds were provided to small and mid-sized community-based organizations to reach the community, and this was again in partnership with the pharma industry. There's a positive action group which was initially supported by GSK, and then a lot of farmers have supported it. And this works again towards improving the living conditions of HIV/AIDS patients and to break down the barriers to improve access to HIV prevention, treatment, and care for poor people living with HIV and AIDS. There is a US patient assistance program wherein hundreds of thousands of patients in the United States without any prescription drug coverage receive medicines free of charge through this program each year. And again, this is supported by multiple pharmaceutical companies. We have this Pfizer Alliance for Healthy Border, wherein the Pfizer is working very closely to improve care for and prevention of diabetes and cardiovascular diseases in people living in US-Mexico border region. And then, of course, we have so many foundations that have helped in establishment of health institutions all over, especially in the developing world. And this is one such example wherein Pfizer helped in setting up infectious disease institution in Uganda. Pfizer is also closely working on this initiative of trachoma elimination, and this is one of the preventable causes of blindness. So it not just supplies with the medicines, but it has also trained thousands of healthcare professionals who have completed several surgeries to treat advanced cases of trachoma. So now, lastly, I would like to share my experience with regards to this weekend project, which I'm undertaking as a PI. And this is a very prestigious project, which is with the GACD grant, wherein ICMR is a funding partner and the Canadian government CIHR is also funding partner, and we are looking at HPV self-sampling. So this is again a multicentric trial wherein we are looking at how women in different regions in India would respond to HPV self-sampling and whether it would be acceptable, whether it will be equally effective or not. But when we started with this trial, we soon realized that other than Tata Hospital, other centers do not have an HPV testing laboratory. And we wanted, it was not really feasible to get all the samples to Tata, because this is a work that goes on every day in the community. So again, we approached Roche, and they connected us to Iogen, and we are working closely with them wherein they collect the samples and take it to the nearest testing laboratory. And we will be able to complete this trial only because of this partnership. So this is the trial of HPV vaccine trial. So coming to the end of my presentation, I feel that Pharma has several roles to perform, and this is a very different role that was performed by Merck during the 9/11 tragedy that happened. So they did not donate any medicines to the hospitals. Rather, they provided helicopters and ambulance services, and their plant location supplied construction gloves, goggles, cots, and beddings. The pharma industry has really stands to the public health needs, the government needs when it comes to emergencies. So I would like to summarize by saying that there is a different image also of the pharma industry. There are many different roles that the pharma industry performs, and it's not just manufacturing and supplying of medicines. I feel the pharma industries have a big role to play in addressing the public health challenges. And I think in collaboration with other partners like the government, the academicians, NGOs, etc., they can contribute hugely in promoting health of mankind. Thank you.
Thank you so much, ma'am, for an excellent session and steering us through various critical and important aspects for the benefit of the students. Thank you so much. I do have one question to you, ma'am. Considering the global nature of public health challenges that are there, how can academic and industry partnerships contribute to addressing health disparities and ensuring access to essential medicines in different regions?
The academicians, they can collaborate on lot many aspects. For example, for research, we do collaborate for research, but when it is identifying a public health issue in the population and trying to address that particular issue, I think that really works for the larger benefit of the community and the public as such. And it's not just the research, as rightly mentioned, access to treatment, and access to the newer therapies, and again, capacity building of the physicians in that particular region to actually deliver that medicine, to be comfortable in prescribing the medicines, and also community at large in terms of accepting the newer treatments and health education that can be provided to the community. In fact, a lot of times we get a lot of nice posters and nice health education material that is developed by the pharma industry for addressing the non-communicable diseases issues, and we had a lot of nice posters and health education material that came up for tobacco cessation, for alcohol cessation services, etc.
Thank you so much, ma'am. Thanks a lot for being here with us today, and thank you so much for addressing the concern. Thanks a lot, ma'am.
Thank you.
Moving on to our next session, which is Omni-channel Dynamics, Transforming Medical Affairs. And for that, we have our first speaker of the day, Mr. Hideyuki Shiba. Mr. Hideyuki Shiba is a global omni-channel lead in biopharmaceutical medical at AstraZeneca and work at developing omni-channel capabilities for medical and integrating it into enterprise model. He has over 20 years of pharmaceutical experience in various local and global commercial medical, including medical science liaison, MSL manager, and medical excellence. A very warm welcome, Mr. Hideyuki. Our second speaker for the session is Mr. Veelun, business partner, medical omnichannel AstraZeneca. Veelun is a seasoned professional and works closely together with medical teams to help develop and deliver omnichannel strategies across the markets. Welcome, Hyde and Veelun onto the stage.
Thank you, Ashish.
Thank you, Ashish.
Thank you so much, Hyde and Veelun, for joining us today. So without any further delay, I would hand over the stage to you for taking it forward.
Okay, cool. Thank you very much. So let me share my screen. This is a slide.
Yep, it's visible.
Okay, cool. Thank you very much for the nice meet you, and hello everyone. Nice to meet you. So my name is Hide Shiba. Thank you very much for kindly introduction of the Ashish. So I'm medical omnichannel lead in the biopharmaceutical medical in AstraZeneca. It is my great pleasure to be here today together with my international colleagues for Wei Lu to share and giving some discussion about the omnichannel dynamics in the medical affairs. So next slide, go into there. Okay, so let me start. The omnichannel is a concept of a way to engage customer. So it has been mainly developed and progressed in customer business field. And as you may know, some famous examples such as like Netflix or Amazon, Apple, and Nike, etc. So those have already been well installed in our day-to-day life. So for instance, if you want to fix something problem of your iPhone, you can choose multiple options asking support from Apple based on your preference. So like visiting Apple store near your location, or finding some solution on the Apple website. Or you can also call directly customer center to have a chat with operator, or even using chatbot recently. But in any ways, you can expect Apple to have some level of the basic information of you and give tailored response based on your situation. And even the company could provide personalized kind of say follow-up the communication afterward. So I know, yeah, of course, the reality is not in a perfect world for now, and you may sometimes have annoying experience. But actually, those consumer business service became different world compared with the world a decade ago. And now, pharmaceutical industry has been looking at how this omni-channel approaches can be utilized in our customer engagement. So today, I will share the role of the medical affairs in omni-channel and what is omni-channel and why we need this approach in this medical affairs activity. And then the later session, we will share real example and how medical affairs can utilize this omni-channel from their experiences. So before moving into the discussion, what is omni-channel in medical and why it needs? So let's start from reminding the role of medical affairs in pharma. So I think you will learn and keep deep dive about the role and responsibility of medical affairs from other speakers today. So I will quickly and very briefly go through here. So you can see the medical affairs is playing like a critical role in pharmaceutical industry recently, and recognized as the third key pillars alongside R&D and commercial organizations. The medical affairs is scientific leaders who represent the real world, like clinical needs of patients, healthcare professionals, and other decision makers across internal, scientific, and commercial partners as well. And our scope between the medical strategies covers across the product life cycle. So it means you can see the bridging, starting from development work in R&D, in the pre-launch phases, and also post-launch commercial activities. So this is the uniqueness of the medical affairs, positioning of the medical affairs. So we do this by interpreting and contextualizing emerging data, and also generating real-world evidence, and engaging in peer-to-peer scientific dialogue with HCPs, and also identifying clinical practice insight and educating healthcare providers and other decision makers on the safety and effectiveness of companies' products and medicines. So importance of the role of medical has been increasing recently and well recognized in the industry. However, as you can see, our environment, the field in the pharmaceutical industry and the healthcare industry as well has been dramatically changed recently. And it impacted our ability to communicating healthcare professionals appropriately. So let's see these dynamics first. So as I mentioned earlier, we are currently facing dynamic changes in the healthcare industry. So especially for the information, so like evolution of the medicine and the science is massive. So medical knowledge is expanding faster than human ability to assimilate and apply it in practice effectively. So as you can see on this slide, so like building the medical knowledge took 50 years in doubling these knowledges took 50 years in 1960, but it shortened to 7 years in 1980, and then 3.5 years in 2010, and now it's slightly 3 years ago, but in 2020 it was just 73 days. So you can surprise the medical and the new latest information, the volume of the information goes double just in 2 months, about 2 months. So you need to very need to study hard, obviously, but it means HCPs are experiencing like information overload now, very complex information, and the scope of what you need to learn are expanding recently. And another big impact comes from the digitalization, obviously. So can you guess where this picture are taken? So yeah, let's guess. But yes, this is a papal conclave. It was held in the Vatican in 2005, and also after 8 years, at the 2013, the another conclave was convened in the Vatican at the same place. But you can see during these 8 years, the world has completely changed. You can see in this picture. So like everyone now has a mobile device. And also there are a couple of iPads as well, you can see. In that short period of time, especially in terms of the technology, we are starting to share. And also we are starting to capture the network. So we belong to more of a digital network where we share our experience. It means digital natives. We call digital natives. Those who are more like familiar with digital technology have been increasing recently. And as the percentages of the physicians who are digital natives are increasing, and the expectation for accessing the content and information are changing. So digital natives, increasingly digital immigrants, expect simple and also instantaneous information, other APIs, and third-party professional website, and others as well. So this expectation of getting instant access to the information has been carried from medical school. Obviously, you are familiar with this situation, and into bringing into professional life as well. So one of the biggest issue these physicians have with website is spending time navigating the site to find the right information they need. And also, the huge impact came from the COVID pandemic period. So we know that COVID has had a huge impact on pharma engagement and also our daily life as well. So before COVID, the most of our contact with healthcare professionals came from face-to-face meeting with the sales teams or field medical teams as well. At the office of the clinicians or hospitals or some of the congress status would be more general occasions in the communication with pharma and the HCPs. But only small portion of contact came from digital before the pandemic status. But with COVID, everything had to switch to digital. Obviously, we have no physical interaction during the pandemic. Obviously, like a restriction of the communication. And everything had switching. And this switch has meant that HCP has become familiar and comfortable with remote engagement. And it has also meant that everyone is now much better skilled and with digital tools than pre-pandemic situation. So this applies to patients as well, who have become familiar with remote appointment with their HCPs in some occasion. And going forward, we know that habits will change and that digital will take up a higher proportion of contact than pre-pandemic situation. But we still don't know what the engagement mix will look like exactly. But obviously you can see these changes, like a shifting to the digital channels, would be recently say more on a normal situation. So it has been totally changed. And then again, so rise of this digital technology is changing the way to access information from the HCPs and the professional perspectives. So today, the healthcare professionals are exposed to various physical and digital channels, so which sources a variety of the information and are often in an uncoordinated fashion. So those leading them to feel overwhelmed with information. And under this condition, as a pharma, so we need to change our approaches with engaging these physicians and evolving our approaches as well. So we need to create and deliver a more like a cohesive experience to our customers. And also, as you sometimes read and learn something like a medical information in the variety of the format. So this came to the this format of the content as well. So for everyone, everything, like a BMJ is a quite major journals in the medical field, creates every publication. They aim for visual abstract, a single or downloadable or something like shareable images. So these can summarize a potentially complex paper in a single images. So there's also the option to download the slide kit or something like get the audio of the presentation. Or there may be an imaging of the infographic that can be shared on social media as well. So this is a kind of content that is in demand, on demand content. So the way the HCP receive and assimilate medical information need to change. So simply adding more the material and or time will not be an effective coping strategy. So fundamental change has become imperative. So HCPs are relying on pharma to help to fill these educational gaps. So I think the omni-channel is a way to improve this quality of our customer interaction, so which can help to deliver seamless experience and the right time, right information, and the right customers. So let's see the omni-channel. But also, probably you may hear somewhere, like there is another concept of the customer interaction, which called like a multi-channel. So let's look first, look at what's the difference between the multi-channel and the omni-channel. So the main difference lies in the focus of these two. So multi-channel is product or brand focused from pharmaceutical companies' perspectives. And omni-channel is customer focused. So as multiple channel is product or brand focused, so like a campaign typically brand centric. So we tend to push the same messages and information using various channels, but it's very much one-way traffic from pharmaceutical company to the HCPs. So which means the pharma delivered what we want to deliver to the HCPs, whatever the channels. That is, a way of the multi-channel approaches. On the other hand, omni-channel is very much customer-centric with a more personalized approaches and allow for both push and pull messaging. So it uses the personalized content delivered via channels and tactics that are most likely to resonate with customers. So it aims to meet customers where they are with the information they need. And HCPs pick and choose where, when, and how they want to engage in getting the information. So we still push content and messaging, but there's also pull on behalf of the HCPs. So omnichannel is also the heavily data-centric approaches. So we look to measure both online and offline data related to our customers' interaction with our content and with our field forces. So we are giving the customer the tools to focus on the content and the channels they want at any given time. So let's see the definition of the omnichannel in AstraZeneca. So in our company, omnichannel is defined as, the seamless customer experience and personalized using real-time insight, coordinated across physical and digital channels. So this is the key to remember, very keyword like type of things. So physical and digital coordinating across, so let's start to break down each key, keywords. So the seamless means that all channels and the contents are integrated together to deliver a clear and also single, well-orchestrated narratives. And second, the personalized. So it means that communication reflects both specific needs of customers as well as their preference for communication channels. And third, the real-time. So real-time insight means that we are informed by a deep understanding of the customer developed using a broad set of data. So this rapidly informs the next best action to the company and through the real-time analysis of the impact and the data. And lastly, and physical and digital means that all customers' contact is informed within a single system. So it means including the personalized and non-personal communication across all functions which pharmaceutical company provides. And next, also let's see the key components of the omni-channel approaches. So there are 4 major areas of capabilities or like competencies we need to have to operate in omni-channel ways. So these 4 are customer, content, and the channel, and lastly data. So these allow us to create optimized customer experience. So let's start from customer. So having the data driven of the customer. So the beauty of the omni-channel is that we can measure all customer interaction with our content and understand the different ways of the grouping customer for the purpose of personalized engagement. So sometimes we are utilizing persona, which is not like which is a kind of say the mark and the typing of the customer's characters. So like what the preference, what the tendency, and they have. So these grouping provide pharmaceutical company to provide much better like tailored approaches. The next is the content. Of course, the content, some famous personnel say like content is a king. So ability to develop content that meet customer needs and provide right and accurate information in optimizing a variety of the formats is quite critical. And thirdly, the channels. So effective use and optimization of engagement channels with allowing our customers access content through the way they like and time they want. And lastly, the data. So effective like use of data to develop insights that lead to specific and informed actions. So data wrap around every customer interaction, and we measure all interactions. So we can take data about our customers and our contents and also our channels and use it to create insight that will enable us to make a smart and informed decision. So we can uplifting our quality of our strategy. So having the right data is vital. So if we are to have the most impactful like customer experiences, so data is quite critical components out of these 4 for the omni-channel approaches, the versus traditional multi-channel approaches. And this is my last slide. So then for summarizing, so with our omni-channel approaches, we still do all the same things we were doing before. So no like shiny, new, innovative upload, the channels or contents came from omni-channels. So we are visiting our customers face-to-face situation or in virtual. That is a quite traditional way to communicate with HCPs. And also sending email in to informing some of the data or sharing some contents. And also creating a medical website which can allow HCPs to visit and download and view some contents. And also engaging them in a peer-to-peer event, like some symposia type of things. And also seeing them at the Congress event. And sometimes utilizing like a third party outside of the companies, like agencies to communicating to some the HCPs. But however, like these traditional approaches can be evolved more on like strategic approaches with omni-channel model. So channels are connected. These channels are connected and designed to work together. And the content in one channel will related to the content in another one. And also we can more customers. We can move customers like through a personalized experience or content journey. In other words, omni-channel enables us to work in a customer-centric way. So orchestrating and sequencing content to meet individual customer needs, and we are informed by those interaction data to get deep understanding of our customers. So if we use omnichannel correctly and do it right away, so HCPs will feel as though we are respecting their time and a choice of engagement. So we will not be pushing content that they are uninterested in, but providing the information they need and want to know. So this also means that information access will be faster than ever. And for HCP perspectives, and currently, a big challenges for physicians, as I mentioned earlier, is like getting access to or finding right information, so right time. So if we get all three of these things right, so we build trust with our HCPs. So this is the beauty of the omnichannels and why we need to evolve our approaches of the customer engagement. So I was going through something like a concept on and what is the omnichannel, why we need these approaches. So then the Wei-Lu will share real example from his experience and work from the international region. So I'll hand it over to Wei-Lu.
Thank you, Hide. Yeah, so I'll be sharing two projects that International has done that contributed significantly to our omnichannel strategy in medical affairs. So first will be the Omni Congress project, right? So in the past, interactions between pharma ACPs has always been highly structured and controlled. But with COVID-19 and the rise of digital technologies, we are now in an era of new era of omnichannel engagements. And this shift presents us with both challenges and opportunities for the medical affairs, right? So there's increased content demand. Omnichannel marketing requires a vast amount of diverse content to cater to different channels and HCP needs. There's also a pressure to produce content quickly and efficiently while maintaining quality and compliance. So this got us thinking, how do we take an event-based offline channel like a conference and congress and turn it into a continuity of communication before, during, and after, and create engaging material that doctors can access in a convenient way. So one of the challenges that we had around congresses has always been high cost and limited budget, and we have a commitment to drive sustainability, right? So that means we have a limited number of slots that we can send HCPs to the congresses. So instead of bringing HCPs to the congresses, we wanted to bring the congresses to the HCP who are not able to attend them physically. This allows us to expand our reach with this model across international markets. International covers over 20 markets and regions across Asia, Latin America, Australia, Russia, Middle East, and Africa, right? So this was an ambitious project between the medical team and the digital team. It's where they coordinate the operations across all these 20 markets and clusters who all have different maturity, compliance, and regulation requirements. So for this project this year, we covered 5 congresses: ESCO, ERS, ERA, ESC, and ESMO. Sorry, next slide, please. And how do we do this? We brought in a video platform to host all the content. We brought in a specialized video team that we send out to all the congresses that they film all the daily updates on the site, send it to markets for approval, all within 24 hours, right? So this allows us to build omnichannel customer journeys before, during, and after the congress. Before the congress starts, we set up the pages across the different markets, send out teasers, invitations to the HCPs. Once the congress starts rolling, we produce daily summary videos, 2 to 5 minutes of different KEEs sharing the latest updates from the event itself. Within 24 hours, the videos are up on each of the market pages based on the market requirements, right? And the markets will start sending out integrations and emails, and different communications based on HCP personas. For example, for Oncology Congress, we produce content for both breast cancer, lung cancer, gastro, right? And we send this based on the personas that we built within the markets. We also integrated the data flows, so we know that whether the doctor sign up, whether they receive, they open an email, they click through, which are the videos they actually watch, And all of these videos, which are the more popular ones to look out for. And based on these actions, we can build customized journeys and follow-ups for these doctors. And this is just not an online engagement model. There's also for opportunity for MSLs in the local markets to engage with the HCPs who are not able to attend by having meetings and having discussions. Right, so in the next slide, you'll see some examples of these engagements. For example, in Malaysia and Vietnam, they hosted live viewing parties, right? So on top of having daily summary videos, towards the end of the Congress, we also organized a live roundtable with KEs from across the world that share their thoughts about the latest updates in the Congress. And what they did in these markets was to have all the doctors get together, have a meal, and watch the live stream together. And there's also live Q&A sessions that they can put it in, and the KEs are able to respond in real time. So you can see in the lower half of the slide, we have the team that's broadcasting and editing all the content live from the congresses. Even some of the KEs that we engaged, they really love the video. They took the video from us and posted on their own social media channels to reach out to even a bigger range of audience. Right, moving on to the next slide. Just to cover the next project would be the D Academy. Right, so on top of engaging the HCPs, we also wanted to understand how we can empower HCPs. And D in this case stands for Digital External Experts. Right, so what we did was to engage into all these various DEs from international markets who has great experience and influence on social media platforms to share and discuss their experiences using healthcare social media platforms with one another over the course of 2 weeks. And these digital external experts, they are in a position to have significant impact within the ecosystem. They work differently, they have different preferences, and have influence in the new digital world with much greater reach than the traditional doctor. Right. So this discussion that we had generated rich and broad insights on their typical engagement, motivations, best practices, and unmet needs today, as well as their impact on the broader healthcare system. We took these learnings and we developed a strategy and platform with DEs on how we can best support up and coming doctors through this D Academy. Right, so this D Academy is aimed to support these doctors in driving disease awareness in CKD for patients and increase diagnosis through upskilling physicians on the effective and compliant use of social media. And we did this in 2 parts. We have an e-learning platform that's interactive for them to go through different modules. We also have a series of live virtual workshops with breakout sessions with different doctors to see how they can share their learnings from each other, and also the learnings from the most recent modules that they completed. So this program takes place over the course of 3 months to participate on this e-learning platform on different topics, social media best practice guideline, and how to develop engaging content for social media. So we just recently completed the first wave in Latin America, and we've seen great results, especially from those doctors who participate actively in the program. We've seen double-digit growth in their followers, engagements, including likes, retweets, and comments. The quality of content has also gone way up. They started using hashtags, using visual aids, infographics, and this really helped them engage with the audience. And with the success of this first wave, we're also now moving towards expanding the program. Right now, we're running it in Middle East and Africa, and we have planned to expand this project next year to bigger areas and more areas, as well as other therapeutic areas such as respiratory activity. Right, on the next slide, we will share a bit more on what are these modules, right? So it's a total of 12 sessions and engagements covering both technical and scientific modules. Right, things like disease training, privacy, how to measure metrics on your platform, how to deal with negative issues from followers, and specific modules on platforms like Twitter, YouTube, Instagram, and Facebook. And the live workshops is one of the more popular ones as well, on how to get started with social media, develop scientific social media content. After the course, we actually had doctors trying to use their own develop their own content using simple tools like Canva, how to build up their account and build their influence, and use video and live engagement as well. Right, moving on to the next slide. Just wanted to share some key takeaways from both me and Hide on as a need to start moving from multi-channel to omni-channel, and understand how omni-channel can help deliver timely and relevant scientific information to HCPs. And we hope that you're able to understand what are the skills needed to drive omni-channel medical affairs. Firstly, would be digital and technology literacy. You do not need to be experts in all these new digital tools and software, but once you must be able to know what is available and how these tools can help you in your ways of engagement, and how to make use of data analytics and insights, right, to make sure you can deliver a customized approach. Things like what are the TCP preferred channels, right? What is the best time to engage with them? So this also comes to the next point on deep customer understanding. Understand their behavior, their preferences. Do they prefer data on efficacy? Do they prefer data on safety? And from there, you can send them relevant communications based on that. There's also a need for enhanced communication and cross-function collaboration. You need to make sure there's no silo between the different teams, especially medical and digital, so they can build the campaign together and send it out as a whole. And of course, importantly, you need to make sure that you're compliant and make sure everything is follow the code of ethics as well. Right? That's it from me. So I think we have a couple of minutes left Q&A. Pass it back to Ashish.
Thank you so much, Velun. Thank you so much, Heidi, first of all, for being with us here for the benefit of the students out there. I do have received some questions from the students. And the first question from my side is, what challenges do medical affairs professionals commonly face when implementing omni-channel strategies, and how can these be addressed?
Thank you very much for the question. If I can answer to this. So first things would be mindset changes, which is the a way to mention the takeaway messages. Obviously, our medical affairs, the people are very much academic and science-based people. So they are very much familiar with scientific data and peer-to-peer communication with HCPs, but sometimes not familiar with digital or tech type of things. And let's say something like allergic to these type of things. And also challenges might be collaboration with commercial teams as well. So obviously, medical team need to some level of restriction and separation with commercial activities. But obviously, customer perspective, there is no difference, like a sales rep visiting HCPs or field medical visiting them, and company's website providing some information. From the customer perspective, these should be connected seamlessly. But as I mentioned earlier, some of the mindset challenges. Oh, this is the commercial activities. Medical should not touch in. This is medical activities. Commercial is no interest, or you need to follow commercial guidance. These type of mindset within the industry might be more on a need to evolve in an integrated fashion. And also technically, how commercial, medical, or even research and development within the company can make seamless and optimized technical approaches. That is currently we need to tackle, and one of the challenges we are identified. If do you have any idea or thought on here?
Yeah, absolutely agree with you, Hide. But I think a good example would be pre-launches, right? Oftentimes, we see that medical and commercial, they operate differently. But with omni-channel, you should be able to do a whole seamless customer journey, right? It should be connected. All the engagements throughout the journey point should be collected, and both medical and commercial should be able to see what's going on with the journey and the HCP. Make sure they're on the same page when they go out and engage with these HCPs.
All right. Thank you so much, Veelun. Thank you so much, Heidi, for answering that. My second question to you is, uh, how can organizations ensure that their omni-channel initiatives are aligned with the industry regulations and standards that are there in place? So
Yep.
maybe we can have a quick comment from you, Heidi, and then Veelun from you.
Yeah, okay. So obviously we need to follow the clearly need to follow the industry's regulation guidance. So if we can use omni-channel approaches or digital approaches, the rules we need to follow in the communication with healthcare profession is totally same and not change it. So this is quite fundamental understanding we need to follow. But also there is some of the ambiguity, like there's a no one know how these data, like automated suggestion functionality, affected to our guidance or our rules of the communication. So we need to very carefully to setting these technical setup and also like communication guidance. So need to very much closely working together compliance team as well to follow the guidance.
Yeah. Thanks, Edith. Yeah. I think also one of what the challenge that we often see in medical affairs is there's also a lot of debate on whether medical affairs can do anything proactive or whether it has to be reactive, right? So I think it's important to have the local market compliance and NOMSIC team to heavily involved in these sessions. And for example, for the Omni Congress project, let's say in Egypt, all content has to go through local authority approval, right? So you make sure that all these content are submitted, everyone is in the loop for that.
All right. Thank you so much, Heidi. Thank you so much, Veelun, for being here with us today for the benefit of the patients and also for patiently addressing all the questions that are coming across. Thank you so much for that.
Thank you for having us.
Thank you very much. Bye-bye.
Thanks. So, moving on to our next interesting topic, which is next generation medical affairs, bridging science and patient care. And for that, we have with us Dr. Anil Kukreja, Vice President, Medical Affairs and Regulatory, AstraZeneca India. With more than 15 years of experience, Dr. Anil is a strategic visionary and accomplished medical leader having diverse experiences in pharmaceutical, biotech, and relevant industry. Recognized from forming a very well grounded, responsible, and committed medical team comprising of medical value, clinical research, regulatory, pharmacovigilance, quality, and medical information professionals. Passionate for the patients and having the passion for patient-centric initiatives and the medical strategy, launch readiness, capability building, data generation, and policy saving. So let us join hands to welcome Dr. Anil Kukreja onto the stage. Dr. Anil, over to you, sir.
Thank you, Ashish, and thanks a lot for the PharmaSteer as well as SATE, GS Medical College, and KM Hospital for bringing this PharmaSteer for all of us. I think it's an privilege for us to connect with the postgraduate medical students as well as different speakers and stakeholders, particularly the faculty, on sharing our perspectives based on our experience and the journey. And I think it's very important for us to reflect on the same. I just will need confirmation if my slides are visible, then I can start actually the presentation.
Yes, sir, it's visible now. Yeah.
Okay, perfect. So the topic today, I think it's important for us to understand how the next generation medical affairs looks like, how we translate the science into patient care. And there are not many slides. What I'm going to talk more about conversation from our side, particularly looking at how the healthcare is changing in the changing world. As we see in this slide, there is a uneven global economic recovery. We all know during the pandemic through a impact on the economy. And global economy forecast is to grow at 5.6% in 2021. But again, the low income economies continues to struggle. of course, we see also that particularly in developed countries is there is a growing and aging population. And along with the growth and age, of course, there are different diseases which also come in this population. So 2.1 billion people will be above 60 plus years by 2050. So we have to prepare for, so imagine the population of 7 billion, and maybe it will be 8 or 9 billion by then, but you will see a significant proportion of population which will be age 60 plus. And we need to be keeping in mind about the health and health and well-being promotion, particularly for this population. At the same time, there are different diseases which will be prevalent in this population, which we need to be cognizant about, which will bring the challenges for the drug development as well as challenges for the medical affairs as well. At the same time, we have an increasing burden of chronic diseases coming with all what I just spoke. Close to 41 million people die because of non-communicable diseases every year. I'm talking about the deaths. I'm not talking about the prevalence. Prevalence is far, far more. We also see a emerging and growing importance of digital in the healthcare. Using pre-COVID levels. We also is planting 64 million trees as a part of repopulating the whole Meghalaya. So we are trying to do a plantation of the trees, which not only provide the clean air, water, and sufficient food, but also it helps in the employment in this part of the world, which is Meghalaya, where lives and the economy was getting affected because of the deforestation. So we had this initiative, and I think it's important that we keep this climate change also as, and the health impact of climate change also as one of the important emerging priority in the coming years. Come to the last bullet point, which is cancer as a leading cause of death. I think it's very important that we need to say that, look at the estimates from WHO. Cancer has already become a leading cause of death globally. And these are the important changes which are happening in the world. Now, let's look at what is happening in India. India is also currently going into a triple transition. So we have economic transition, we have a demographic transition, and we have a epidemiological transition. And here it's important to say that although we are progressing as a 5th largest global economy, we have 67% of the population in the working age population, which is a good thing from a demographic population and from economic population as well. But let's look at the epidemiological point of view. 61.8% of all the deaths will be contributed by non-communicable diseases. And that's the change which we are seeing versus just 2 decades, 3 decades back, right? It was just 37%. So almost you are seeing doubling of the non-communicable diseases. Because of all the transitions on economic and demographic, you are also inviting the new non-communicable diseases as a burden. And the challenges, particularly in India, are 5 A's. One is lack of awareness. So awareness is limited. Suboptimal access to the healthcare. Affordability challenge, because per capita income in India still we are far, far behind. Although India is becoming a 5th largest global economy, but per capita income we are far behind in the lower rung of the countries. Even our neighborhood countries are far better from a per capita income point of view. There is the absence of human resource. When we say absence, means we need human resources. There is a dearth of human resources which are required actually for providing the healthcare to the population. Particularly, this is all the more important in the rural areas. And of course, accountability, or maybe we can say lack of accountability. So I think these are the challenges which are there. And this lack of accountability is there across the spectrum, right from the individual patient perspective also, or maybe from the citizen perspective as well. So these are the transitions which are happening in India as well. Now, how is the medical affairs evolving? So if we have to be really a bridge between the R&D and the patient care, we need to see how we have evolved over a period of time. So in the earlier years, medical affairs was very, very reactive and supportive. So we used to call it as a medico marketing role, right? Medical is supporting the marketing team. Then came the era where medical started delivering individual projects. And that's where execution excellence came as an important, I would say, part of the medical affairs. We are at a cusp in India, particularly. I can talk about that we are evolving from being an execution excellence to being a science leaders and strategic partners. And this is where we are currently as a medical affairs organization, particularly when you ask me my perspectives of being an AstraZeneca, where are we looking at? So we are currently at a stage where we are scientific leaders and also strategic partners to all the internal organizations, so that, and also strategic partners to the healthcare ecosystem, strategic partners to the various states, various academic medical societies, and also with various, I would say, stakeholders in the patient journey or providing the healthcare to the population. Now, are we at a stage? The next stage for us will be being movers and influencers. And movers and influencers means you are influencing the healthcare ecosystem to change. We are generating the evidence which provides the call for action. And we also are moving and influencing the whole cross-functional team, where medical affairs is in the leadership position, and the entire cross-functional team looks into the strategies which medical is proposing. So I think this is the journey we have been. Now, this evolution, if you look at the deeper aspects of the evolution, we are right from earlier, we were thinking more about how do we generate the real world evidence. Yes, that's the important part. The second, with the various topics and also the healthcare systems. Very important role. I'm sure you would have heard from the various medical affairs leaders who have spoken to you. One of the very important role of medical affairs is generating a valuable insights. So when the medical affairs people interact with the doctors, with the top KOLs, with the top key external experts, in those interactions, which are peer-to-peer interactions, you get a lot of valuable insights. And that's very important, because those insights will form not only the medical strategy, but sometimes these insights are so valuable that it forms the whole organization strategy. And that helps in ensuring that the strategies are right. And fourth, most important, are useful medical projects. And I can talk and give examples of many projects which medical has run, which has really improved the patient outcomes through demonstrating a elevated practice. And one of the initiative I can talk about here, particularly which is very close to my heart from the current work which we are doing. So we all know bronchial asthma. Bronchial asthma, there are so many lakhs of patients suffering from bronchial asthma. The current GINA guidelines, the global initiative, particularly in asthma, the GINA guidelines, which is the gold standard here, the GINA guidelines recommend 5 stages by which the asthma can be treated. So it can be on-demand inhaler, it can be a maintenance therapy inhaler, it can be inhaler which has inhaled corticosteroids to have a local disease control. At the same time, you can have, so this goes on. The last stage is where it's a difficult and uncontrolled asthma. And here the patients have an opportunity to get either a oral corticosteroids, again, burst of oral corticosteroids, or you have to take the maintenance oral corticosteroids. And there are advances where you can actually avoid oral corticosteroids, because we all know as a medical affairs leader that oral corticosteroids create a lot of adverse events throughout the body. It could be osteoporosis, fractures, and everything, right? So one of the medical project could be that can we create a protocol where severe asthma patients can be identified, and these patients can be given right information, where patient has the meaningful discussion with the doctor and chooses the right therapy. The therapy could be the advanced therapy, which is in the form of biologics, or continue the burst of oral corticosteroids, depending on the economic and affordable position, particularly for the patient. But this medical project, in terms of creating a severe asthma clinics and centers of excellence, has really demonstrated that a patient outcomes have significantly improved with this medical project. So this is just one example. Similarly, there are so many other examples which I can talk about, which our team is currently doing. So evolving from this real world evidence to innovative evidence generation, similarly from medical engagement to transforming the medical engagement, from insights to actually action, in terms of how can these insights be useful for access, where medical projects can enhance the access to the molecules. And similarly, looking into insights, what are the leadership building new capabilities which are required in the organization to further evolve in the medical affairs to become a next generation medical affairs. And that, if you see, and recently I was reading the McKinsey 2030 vision for medical affairs. I think medical has really progressed well. What is currently lacking is, do we wear the enterprise leadership hat to drive the patient impact at a scale where it should be driven? I think that's something which we have to evolve further into. Are we collecting the data end to end and analyzing the data to create a very differentiated medical strategies? I think that's the area where we will become a next generation medical affairs. Are we generating the evidence which is aligned to the other stakeholders? So is this evidence required for shaping the policy? Is this evidence required for resulting into a call for action for access? Is this evidence required for orchestrating the medical engagement also? So these are the transformations which are required to evolve and become a next generation medical affairs. And truly speaking, if once we reach into that stage of medical affairs transforming, we will definitely have a far bigger and far reaching impact through partnerships on many more eligible patients which are eligible for our kind of therapies which we are bringing in the country. Now, one of the very important revolution which is happening, which will make medical affairs as a next generation medical affairs, is digital. And building our scientific presence beyond the traditional channels is something which we can attain through digital. Engaging and partnering all these digital key external experts, the digital channels for communication, digital channels for collecting the insights, particularly through social listening, and of course, communicating our science to reach to the far more important stakeholders. There, the digital definitely play an important role. And most importantly, what I like in digital strategy is we will be able to measure our impact in far more better manner compared to how we are able to measure through a traditional medical affairs. So I think digital is going to play a very, very important role. In fact, now what we are talking about is omni-channel. So omni-channel contains both the digital and the physical both. So which is also called as phygital, but we are calling it as a omni-channel. So it means we are trying to ensure that whether it is medical engagements, whether it is evidence generation, how can we leverage multiple channels, physical, digital, omni-channel, all to create an impactful medical affairs. Now, what are the capabilities which are required? And I think it's very important aspect, particularly when we are talking about next generation, because all these what I'm the mindset, change the mindset.
So while Dr. Anil joins back, I would be announcing because I have observed that many students are reaching out. So let me clarify the details for the assessments which are going to happen for the internship on the day 4, which is on 16th of December. So stay tuned for that. At the same time, I would also be sending the topics revolving around the poster presentations for those who are not eligible for the internship. So all the details would be shared with you on 16th, and we would be sharing the overall perspective around it, and stay tuned for that. I think we got Dr. Anil back. So what are you?
Sorry, at what time I was, I don't know how much I was audible.
So I think it was only 10, 12 seconds, sir. That was all. Yeah.
Okay, are my slides visible once again?
Yes, your screen is visible, sir. Yeah.
Okay, perfect. So maybe I'll just go back. I think was I audible till by digital?
Sir, on the last slide. No, just before, one slide before that. Yeah, slide number 5. Yeah.
Okay, so just to re-emphasize and just to bring this. So these are the this is how the medical affairs is evolving. And what I was mentioning is the digital and omni-channel will play a very important role, not only to build our scientific presence beyond the traditional channels, but as we have seen, a lot of young physicians are coming in the system and they are tuned to digital channel. They want to get the information at the time when they need information, at the time when they need the insights. So it's very important that our presence, the medical affairs presence, is there in all the such kind of digital channels as well. I think very important part is we need to engage and partner with the stakeholders who have a digital presence. So we are talking about the terminology called as digital external experts, DEEs, not the KEEs. KE is the key external expert. Now we are talking about digital external experts. Most importantly, by being present in the social media, you get a lot of insights which will help us to shape our action and the strategy, particularly for all these stakeholders who are predominantly present in the digital channels. And also it will help our science to reach new audience, far more deeper, far more broader. And as I was saying, digital helps you to evaluate the impact also in a much better manner in terms of, for example, I don't know when a physical CME happens, how many people do actually attend for how long. Whereas in digital, you can measure the exact time when the person is there listening to you, and if you can make it more engaging as well. So I think we will be able to measure the impact in a very different manner, particularly by using the digital channels. And I'm sure there were more insights from the earlier talk as well when people spoke about omnichannel. Next generation medical affairs requires huge capability building. I think most important, I will talk about the business acumen amongst the medical affairs. This will help us to understand the marketing and business lingo, and we will be able to deliver our value in a far more impactful manner. It will also, most important capability also is how do we influence without authority? How do we deliver our projects with the operational excellence? How do we communicate with impact? How do we understand the healthcare systems so that we can partner with them more effectively? How do we partner and collaborate with various diverse stakeholders to shape the whole disease landscape? How can we use the real world data which is getting generated? We have an immense, and India is considered as a gold mine in terms of data. Maybe it is spread across all over. How can we take efforts to generate the meaningful data which helps in communicating with impact? How do we negotiate with payers, policies, and how do we shape the policies? How do we negotiate with technical advisory boards, particularly who are advising the government? And more importantly, being agile and also ensuring that we know how to tell our story. And that will make a medical affairs more impactful. Most important, by being a next generation and evolving in medical affairs, what are we trying to achieve? The most important person at the center of everything is the patient. We truly want to make a difference in the patient's life by changing the landscape and clinical practice so that patient has access to the best care possible when they need it. I think that's something which is fundamental for the medical affairs and the next generation medical affairs. So with this, I'll just thank all of you for your kind attention, and absolutely, if there are any questions, more than happy to share my perspectives on those questions as well.
All right. Thank you so much, Dr. Anil, for being with us today and steering the students and explaining about the future fit capabilities that are there in place in terms of the next generation of medical affairs, which is yet to come. Thanks a lot for that. We do have received some questions from the students. And my first question to you is, how do next generation medical affairs strategies vary or adapt to different healthcare system and global contexts that are there in place?
Yeah, very good question, Ashish. And I think most important for us is to also understand. Therefore, one of the capability which we need to develop within medical affairs is understanding the healthcare ecosystems. In India itself, let me speak about it, right? So in India, for example, there are certain healthcare ecosystems like, for example, Army, central government health employees. Then you have a state government health employees. We have a blue collar workers. We have railways. We have autonomous institutes. We have various state governments. They are at a different level. So healthcare ecosystem is different from an access point of view, different from an awareness point of view. You may have different diseases burden as well. So understanding these healthcare ecosystem is very important. And that understanding and the mind, it is not only understanding about the healthcare ecosystem. What's the mindset of these stakeholders? What do they want to achieve? And that will help the whole organization and medical affairs especially to do strategies and initiatives and tactics suited to the different healthcare ecosystems. And for example, I'll give you an example of a healthcare ecosystem where They have access to all the best treatment options, but they do not have access to the diagnostics. Now, what should be the medical strategy? Medical strategy here is improve the diagnostic rate. Automatically, they will get the access to the therapies because therapies are available. Diagnostics is not. So therefore, the medical strategy will depend on what are the unmet needs of that healthcare ecosystem. And therefore, addressing those unmet needs will be important responsibility for the entire organization. But predominantly, medical affairs will play an important role. Now, there are blue collar workers, for example, ESIS. You do not have awareness. The 65% of the blue collar workers are not even aware of the basic information about diseases. So there, the most important medical strategy will be how do you empower and make them more aware about the diseases so that they take the responsibility of their health. So just two different examples, practical examples, which can help the audience.
Thank you so much, sir. My next question to you is, since we are ever evolving ecosystem right now, so how the technological advancements which are there in place are contributing in enhancing collaboration with healthcare providers to ensure that latest scientific information is getting translated into effective patient care?
Yeah, thanks once again, Ashish. I think whoever has posted this question from the student, I really thank him. We are at the edge of technical revolution which is happening. I spoke about digital, and I'm sure the earlier speakers also spoke about the omni-channel. Very important is that I'll give again one or two examples where innovation and technology has contributed significantly, and we are really proud of our collaboration with the startups who are shaping this healthcare ecosystem. As we all know, non-communicable diseases, particularly, for example, acute coronary syndromes, myocardial infarction, the best time to get the treatment is the golden hour. If golden hour is lost, you have a severe myocardial infarction, patient may die, or patient may get into the severe compromised heart function and therefore heart failure. Now, if you want to prevent that, the best thing is to diagnose in that golden hour. And here technology can play an important role. The general practitioners, the primary care health providers, they do not have access to the cardiologist immediately, but they have the ECG machine. Now, can we connect this machine through a cloud computing to a cardiologist, where cardiologist gives the decision and diagnosis, and this diagnosis reaches to the primary healthcare professional within minutes, and the immediate care can be provided. And that's important life-saving measures. Through our hub and spoke model, collaborating with the startup called as Tricog, we have the project called as Heartbeat. We have had 50,000 ECGs, saving close to 5,000 lives because of this initiative. So such kind of technologies are there everywhere. I have another example to share where we know that the lung cancer diagnosis is very late, stage 4. And stage 4 survival is 5-year survival is only less than 5%. Can we diagnose this lung cancer patients early? And you can use the technologies. You can use the questionnaires. You can screen the high-risk patients. And if you are able to diagnose early, the 5-year survival improves significantly. So this is how technology innovation can help translate the benefit for patients by partnering with the various stakeholders, startups, technology, healthcare ecosystems, states. We all have to come together to ensure that the patient outcomes improve. And therefore, one of the skill I spoke about in the next generation medical affairs capabilities is influencing without authority. We don't have authority to all the stakeholders, but we need to identify the stakeholders, find out who are having the common mindset, bring them together to improve the patient's outcome.
All right, sir. Thank you so much. And my last question to you is, and this is regarding ethical implications. So, are there any ethical considerations that medical affairs professionals need to be mindful of when integrating scientific advancements to the patient care strategies?
Again, a very good question, Ashish, from wherever it's coming. Really appreciate this question. Of course, there are ethical dilemmas in each and everything what we do. We always have to keep our values in front of us, our behaviors which are right from a patient point of view. 2 or 3 ethical dilemmas which are always there in patient-centric strategies when we are deploying is most important is patient privacy. We need to be respectful of the patient privacy because this is a confidential patient condition which should be known only to the patient and the caregiver family. Now, this information, even if we are deploying or implementing any patient-centric strategy, needs to be in a restricted manner, of course, through a proper professional third parties who are well-trained, who are diligent about the patient privacy and ensures that the patient confidentiality is always paramount. And by deploying the systems and automation, all the patient identifiers are removed. For example, even all the initiatives which I spoke about, whether it was Project Heartbeat or even Project End Lung Cancer, which is early nodule detection in lung cancer, both the projects, no patient identifiers goes. It is only the ECG or X-ray goes, and the diagnosis is received by the doctor, so that the patient confidentiality is protected and only the doctor and the patient knows that what is the how the technology has been integrated. Similarly, when we talk about it needs to be one, of course, as a pharma company, we definitely implement, we have a patient privacy training. All the stakeholders are trained, but most importantly, even the third parties who are involved in any medical projects, they also need to ensure that they have the right training, right mindset, so that the patient privacy is absolutely protected. So this is just one example of doing right thing, but there could be many more examples of processes. So you have to implement the processes so that adherence to the processes will help us protect that we are compliant to the regulations, we are compliant to the processes. At the same time, we are offering the services to the patient without compromising on their patient privacy and confidentiality.
All right. Thank you so much, sir. Thank you so much to the students for asking amazing questions. And thank you so much, Dr. Anil, for responding to all the questions patiently. Thank you so much for being with us today.
Thank you. Thanks, Ashish. All the best to the students for the remaining part of the program as well.
Thank you, sir. So let us now move on to our next crucial topic, and which is the crucial role of medical affairs in pharmacovigilance and regulatory. And for that, we have with us Dr. Kirtan Bhatt, Medical Affairs Manager, AstraZeneca Oncology. Dr. Kirtan is pharmaceutical physician with more than 10 years of the experience in multinational pharmaceutical companies. Dr. Kirtan has experience across various strategic domains, including medical affairs and clinical research, and has led various industry-leading initiatives which help to shape up the clinical practice at scale. With that, let us join hands to welcome Dr. Kirtan on stage. Dr. Kirtan, over to you.
Thanks, Ashish. Am I audible?
Yes, you are.
Okay. So are my slides visible?
Yes, it's visible. Yeah.
Okay. So good afternoon, everyone. Thanks, Ashish, for a kind introduction. I'm going to talk about elevating patient safety, the crucial role of medical affairs in pharmacovigilance and regulatory affairs. I'm Dr. Kirtan, as Ashish mentioned. I work as a medical affairs manager for AstraZeneca India. In addition, I'm also the international breast cancer medical lead for AstraZeneca International Region. So before I jump into the topic, I would like to briefly discuss about my journey in pharmaceutical industry. Ashish briefly alluded to it. So I started off as an MSL or regional medical advisor, as some of you would call it, in with one of the pharma MNC in oncology and respiratory therapy area. Following this, I moved into a head office based role, was a medical affairs manager for lung cancer and immunotherapies. And then I decided to move away from medical advisor position into clinical operations to manage clinical trials across lung, breast, and prostate cancers, where I spent about 2.5 years. And then I moved back to medical affairs to work more closely with breast and gynecological malignancies. So that's about me for over 8 to 9 years in the industry, and for different experiences in medical affairs function as well as in clinical operations. And in addition, as I mentioned, for the past 6 months, I'm also taking up an additional responsibility for the international region of AstraZeneca for breast cancer. So my topic might have more examples from cancer related space, because that's the therapy area that I have always worked on. Really passionate about oncology and how we can make a difference to patients in oncology space. So moving on to what medical affairs role would be in patient safety. I would like to describe these under 3 different headings. First is how we can collaborate with different cross functions to manage risks, how we communicate these relevant safety informations to internal as well as external stakeholders within the industry, internal being our own teams within AstraZeneca, and external being the healthcare professionals, be it doctors or the paramedical staff. Then I would finally touch upon phase 4 studies, real world evidence generation, and how we manage or how we play a key role in patient safety there. Moving on to collaborative risk management. So there are different types of organized data collection programs that any sponsor or a pharmaceutical industry would take up. These are mainly bucketed under 4 different things: early access programs or named patient use programs, patient support programs, investigator-initiated studies or externally sponsored research, and then there are post-authorization safety studies or non-interventional studies. Let me deep dive a bit onto each of these to explain what these mean. So early access programs or named patient use programs are basically nothing but programs for those drugs which are indicated for serious or life-threatening diseases for whom there is no sufficient therapeutic options or no other therapeutic option is available. The drug for such disease is still to be approved within the country, and it is made available on compassionate grounds to an individual patient who might be in need, and this is being prescribed by his or her doctor. So in these programs, what as a sponsor we do is that we establish a channel through which a patient is able to obtain an individual patient license, which is issued by our central licensing authority. Based on these licenses, the patient is able to import this drug into the country, and as a sponsor, we can always establish a channel to help import this drug. And it goes through a partnership with probably a CRO, or it could be a direct route as well. So as a sponsor, we are responsible to ensure that the patients who are taking this drug, which is currently not yet approved in your country, is also being safe for them. So it is our duty to collect adverse events for these patients and report them as well. Now, this would also depend sometimes on whether your regulations permit to report these adverse events in a solicited manner or a spontaneous manner. So that is about the early access programs or named patient use programs. The second is something called as patient support programs. So by patient support programs, what we mean is that after the drug is launched into the market, there are certain programs that a company offers that, if the drug is being a very expensive drug, and most of the oncology drugs are, there are certain support programs offered to the patients which can offer the drug at a subsidized rate to patients. And for this, we need to have certain kind of documentations in process from the patients themselves. And as a company, we cannot be accessing the patients directly, and we cannot be having their personal data on our systems. So we partner with some of the agencies who would help us drive this program or operationalize this program. So these agencies who partner with us also need to be trained on various adverse events which are there for this particular drug, which is for which the patient support program is being offered. In addition, it is also their duty to provide us an update on how many patients are being, you know, how many patients are using this drug, what kind of adverse events they are observing. If there is any report of adverse event, they can always write directly to AstraZeneca as well. And then they can also report to those agencies who can provide us data. The third bit is on investigator-initiated studies or externally sponsored research. Investigator-initiated studies are a self-explanatory term. You know that these are initiated by external investigators, and it is only the sponsoring part or the funding part that's taken over by the sponsors. Here again, it is a requirement for the sponsors to collect adverse event data and report it to the regulatory authorities or institutional ethics committees as required. And the fourth and the final part is on the post-authorization safety study and or non-interventional studies. So I would discuss this post-authorization safety study in my next section as well. But just to highlight a bit on this part is that these kind of data collection can be done in two ways, either primary or secondary data collection. The primary data collection would mean that the we are actively soliciting the adverse events from those patients who are using the drug in a non-interventional study. So by this, I mean that the patient is being prescribed a drug and we are only collecting the adverse event data. And that's what the protocol requires. The secondary data collection means that the doctor himself or herself is collecting these adverse events, and we only collectively use this data, which is gathered by these doctors to uh, add these data onto our centralized systems. So those are the different collaborative risk management programs that we can participate in as a medical affairs professionals. And this requires not just efforts from medical affairs, but it requires a lot of efforts from cross-functional teams. By cross-functional teams, I mean that there are various teams within a pharmaceutical company. It could be patient safety, it could be market access, it could be marketing, it could be strategy team. So these are the various teams which come together to run these programs and also manage the adverse events part of it. What is the second topic in this is that communicating relevant safety information to various internal as well as external stakeholders. So first I would talk about external stakeholders. Whenever we are launching a product into the market, it is our duty that we explain or educate the healthcare professionals, not just the doctors, but also the nurses and paramedical staff on important side effects of any new drug that is coming to the market. And again, here quoting an example of oncology, because in oncology, there is a lot of development that is happening over the last 5 or 6 years. Many first-in-class molecules are coming to the market or which are being made available for treatment. And with this, also some of the newer side effects that come into picture. There is a lot of discussion on how we manage interstitial lung diseases or how we manage decrease in left ventricular ejection fractions or QT prolongations. So these drugs in oncology are to be prescribed by medical oncologists. So are they equipped enough to identify those interstitial lung diseases early? Because interstitial lung disease is something which is irreversible. So it is very important to identify this early so that we prevent it if possible. If we cannot prevent it, we make sure that the progression is delayed of this interstitial lung disease. And hence, that also ensures that the patient is able to remain on the treatment and doesn't discontinue the treatment to prolong his or her life with this oncology drug. So these are some of the things that we come across. By one example, I just wanted to explain what kind of work that we take up in the pre-launch phase of any drug to educate the HCPs on prevention and management of these important side effects. Once the drug is launched into the market, it is also our duty to inform not just the regulators, but also the physicians who are prescribing the drug if there are any important safety updates which are made onto our prescribing informations. Or there could be also an update that one of the indications is being withdrawn because in the initial part of the trials, it was found that the the patient was the drug was showing good efficacy with a particular set of patients. But when a subsequent analysis was taken up, it was found that it did not show much benefit in comparison to the comparator arm in the trial. So at this time, sometimes it also comes to us that the US FDA or the European regulators, they ask the company for more data, or they might also request us to withdraw an indication if that's what they deem fit. And hence it is also important for us to inform our regulators that this is what the US FDA has recommended, and hence we are also voluntarily withdrawing this indication because we have found that this drug doesn't work in a certain set of patients. So at this point, after informing the regulators, it is also our duty to inform the doctors who might have already prescribed this drug onto for this particular indication. To quote an example, that there is, let's say that there is a drug which is indicated for a particular type of ovarian cancer, and it's a group of ovarian cancer patients who are being treated for this with this drug. And later on, we found that the drug actually works in only those patients who are having a mutation or a BRCA mutation than in ovarian cancer, and does not work in the non-BRCA mutant patients. And then we decide to withdraw this drug for that particular smaller indication. So it is our duty to inform the doctors who might have already prescribed this drug for this particular indication. There are, again, so there is any, again, safety information update or withdrawal of these products. This also need to be communicated to vendors or CROs who might be supporting us with these patient support programs. And then those vendors or CROs would be informing the patients as well that you are being prescribed for this with this drug for this particular indication, which currently stands withdrawn by the company. So this also establishes a concept that patients have to be informed, and they can take their informed decision in discussion with their treating physicians whether to continue to remain on the treatment or stop the treatment, because it is quite possible that this patient or one particular patient might be benefiting a lot, and he or she might want to remain on the treatment. And hence it is important for us to inform the patient, not directly but indirectly through our vendors or CROs. It is also our duty again to report any adverse events or potential signals that we come across while we interact with different healthcare professionals, and that also contributes to our overall safety database, which is run globally. What we do internally, we also educate our cross-functional teams, which again includes not just the sales teams, but also marketing teams, market access teams, the commercial excellence teams, and also the wider organization sometimes, because it is extremely important for any employee within the pharmaceutical company to be aware of the adverse event reporting process, and they should be aware of what kind of adverse events are reported, at least for a few of the drugs, if not for all of the drugs. And the last bit would be on medical monitoring and assessment of causality. So we run a lot of projects on non-interventional studies or phase 4 studies or real-world evidence studies. Sometimes we also come across some of the adverse events which are reported by our investigators in these studies. And then it is our duty to also medically monitor these adverse events to assess their causality and give our opinion. The last bit is around phase 4 studies or real world evidence generation, as I mentioned earlier. Whenever we submit a phase 3 trial, or once the data of phase 3 trial is available, we file for an indication or a new drug approval with the Central Licensing Authority of India, which is the Central Drugs Control Standard Organization. Many a times what happens is that once we submit this phase 3 trial application or the new drug application rather, they ask us whether Indian patients were involved in these trials or not. And if the Indian patients are not involved, then it is sometimes there is a requirement that a phase 4 study in Indian patients has to be conducted just to assess the safety of this particular drug in Indian patients. So As a part of the process, we also formulate phase 4 trial protocols to assess safety, and then we reach out to the sites through either directly or through a contract research organization. We run the studies, and then it is also required that we have to collect adverse event data or the safety data, and this is to be submitted to the central licensing authority within a stipulated time period that is given to us as a part of marketing authorization. So these are the basic three components under which we can play a significant role in patient safety, being medical doctors ourselves and being working for medical affairs function within the pharmaceutical industry broadly. Moving on to the next part is how we can help the regulatory function in terms of new drug filing, or what kind of preparation goes through before the product is launched or the drug is launched in the market. So as I mentioned earlier, there is a phase 3 data or a particular data, maybe sometimes in phase 2 as well, because there are accelerated approval mechanisms which are there in by some of the other regulatory authorities like US FDA. And if there is a very high unmet need or the disease is quite rare, sometimes the FDA also approves a drug based on a phase 2 trial, which is called as nothing but an accelerated approval, and this remains contingent to a review, subsequent review by a phase 3 trial. And if the phase 3 trial turns out to be confirmatory, then the marketing authorization stays, otherwise it is withdrawn. So what kind of processes that we undertake before the product is launched? First and foremost is whether the molecule or the drug is relevant for the country or not. For example, if you have a product which is indicated for malignant melanoma, or uh, a very rare type of small lung cancer like mesothelioma. So these diseases are not very common in India, whereas they are very common in some of the countries which have temperate climates. So first and foremost is that we assess from medical standpoint as to what kind of difference we are making this drug into the market. What is the epidemiological data for this drug, and whether we are addressing an unmet need with this or not. So basically, a business case is prepared based on the epidemiological data on this. Once we are aligned between the different teams within the pharmaceutical company, be it medical affairs or marketing or regulatory, we decide on a timeline as to by when we want to launch and by when we want to file for this particular new drug. We also identify if there is a need for local data, and sometimes, as I mentioned earlier, that there is also a condition given by the central licensing authority on whether local data is required or not. Once we receive the regulatory dossiers, we collaborate with the regulatory function to prepare the documents for the regulatory filing for these a new indication or a new drug. These documents involve basically why we want to launch this drug into the India, what is the unmet need that it is addressing, which kind of patients will be prescribed this product, what are the chemistry manufacturing control data, what are the stability data of this drug, who will be the prescribers, whether it will be medical oncologists, whether it will be endocrinologists, or whether it will be cardiologists, depending on the indication that we are filing for. So once all these documents are submitted, we start preparing for the subject expert committee meeting. This is done in collaboration with our global teams on how to go about presenting our data, what are the data that can be expected by our regulators, and so on. And hence, after this, there is a presentation to the subject expert committee, and then the expert committee's role is to give a recommendation and not give an approval. It is the licensing authority which ultimately has the authority to grant an approval, which not just depends on the data of the drug or the clinical trial data of the drug, but there is also a lot of other documentation that's required, which also includes data from manufacturing sites, or what kind of controls or chemistry, chemicals are involved in manufacturing the drug, and then there are certain other aspects as well. All this is usually taken up about 18 to 24 months before the launch, and these are only suggestive timelines, and they can vary depending on what kind of disease you are addressing. Parallelly, it is also there are certain other activities which are taken up mainly by the marketing and the launch excellence team, which are highlighted in blue on this slide. We do a market research to understand how many patients exist on the pool. Then we make plans on how we want to maximize the access to the patients for this particular drug. And as the previous speaker was alluding to, that there are different type of healthcare systems which exist in in any country. It could be a private based healthcare system, or it could be a reimbursed healthcare system, which is nothing but the ex-servicemen contributory health scheme, ECHS, or central government health schemes, and so on. And many state governments also have their own schemes. And in the pre-launch phase comes the activities where we educate the healthcare professionals on what kind of adverse events to expect from this drug and how they should be best equipped to manage these. To give you an example, there could be a new chemotherapy drug which is going to be launched in a country, and the US FDA or the American Society of Clinical Oncology or the NCCN guidelines mention this as or categorize this drug as a highly emetogenic drug. And if the guidelines say that they have to be prescribed or given 3-drug regimen as a preventive mechanism to prevent vomiting in the first few cycles, because most commonly these drugs cause these side effects within the initial few cycles of chemotherapy. And if we are able to manage or pass our way through these side effects in the initial few cycles, it not just ensures that the patients are able to tolerate the drug better, but also they are able to adhere to the drug better, and they can probably prolong their survival times because based on this. So that is about the regulatory aspects of how a new drug is launched, in addition to what I described earlier on the patient safety aspect. And this is how we collaborate with regulatory functions, mainly or in collaboration with our global clinical development teams and also regulatory teams, to file for an indication, plan for the launch, and then ultimately get an approval, and then we launch the drug. The other part is that how we support our global clinical trials in regulatory submissions and approvals. As a company within AstraZeneca, we run a lot of trials in the oncology space, and this also requires a review and approval process by our Central Drugs Standard Control Organization. In the initial part, when we are trying to get the clinical trial application and get an approval, we are expected to submit a lot of documents. Of course, there is a requirement to submit an early phase study data, phase 1, phase 2, and then also the trial protocol, the informed consent forms, and then the CR case report forms that are going to be used for this study. From medical side, we are expected to provide certain documents like what is the unmet need, why do you want to conduct this study. It could be a space where there is no treatment available within the oncology space currently, because not all the cancers currently have treatments available. So there could be sometimes studies which are placebo controlled, or there could be many studies, in fact, which are placebo controlled. So how do we explain the placebo controlled trials? So that comes under the unmet medical need. What kind of innovation that this new treatment is going to bring against the current treatment? So if there is already a treatment available, what kind of additional benefit that, or what is different that your drug is going to offer? So that's what we try to rationalize based on scientific evidence that already exists, as I mentioned, based on the early phase data. And then, as we know that if we cannot do any benefit to the patient, we obviously cannot do any harm. So the data also has to be told to the regulators that what is the risk versus benefit ratio of this drug. And again, we go through the same process that we submit our application to the CDSCO, and then we present our case to the subject expert committee, who gives the expert committee gives their recommendations, and then finally we get an approval. This is not just true for an initial clinical trial application, but also for any protocol amendments that come into picture later on when the trial is ongoing. So this is how we work in collaboration with different cross-functional teams. I mentioned patient safety teams. I mentioned regulatory teams. We have the marketing team, the strategy team, the market access teams, and this is basically the overall collaboration that happens between different teams within any pharmaceutical company when it comes to what kind of role medical affairs plays within the safety and regulatory functions. So that's it from my side. And if there are any questions, then I'm happy to answer. Thank you all for your patient hearing.
Thank you so much, Dr. Kirtan, for that wonderful presentation which you have had for the students out there. We do have received some questions from the students, and my first question to you is: are there strategies for staying abreast of evolving regulations and adapting to changes in pharmacovigilance landscape that is existing?
Thanks, Ashish. Yeah, we do keep ourselves updated with newer regulations that come into picture. Uh, there is a new drug and clinical trial rules which was released in 2019, and there are some amendments that came into picture in 2023. There is a particular rule in that which states that uh, if you are filing for a drug approval, then you need to also ensure that it is addressing an unmet need, and there are certain clauses in that which describe what kind of data are required in order to get a local clinical trial waiver. So based on those criteria, if we are meeting those criteria, if our drug is falling within the uh, rare disease or an orphan drug, then we might get a waiver for a local clinical trial. But otherwise, it is usually required that we have Indian data or data of Indian patients to uh, get an approval for any new drug. So yes, to answer that question, we do have to keep ourselves updated with whatever the regulations are, not just in India, but sometimes even outside India. Because we are talking about the drug approvals across different countries, some of the regulations which are applicable, which may be applicable in one country, may not be applicable in the other country. But the company also has to maintain a consistent stand on what kind of approach they are taking in terms of approvals. So, and also in the adverse event reporting. So yes, so we have to keep ourselves updated, uh, read a lot. That would be the strategy that I would suggest.
Right. Thank you so much, Doctor. In continuation with the read a lot thing, my second question is: given the diverse global regulatory landscape, what approaches or capability areas do you recommend for the students out here so that it would help them to navigate and comply with various regulatory frameworks that exist?
Okay, so I think there are also a lot of uh, so I would probably go back a few years back to when what I did when I was a student. And I used to read a lot about regulations which exist across countries, especially the US FDA, Europe, and Australia and Japan, and then how it compares with the kind of processes that are involved in India. What are the differences and what are the commonalities, right? So these are some of the things that that's what I used to do when I was a student, and that's how and it definitely helped me when I started off my career in pharma industry. So yes, there are also you would also get a lot of documents online. Of course, you need to check the authenticity of that. You could also go through some of the websites which these licensing authorities have, and you can try to understand what are the new drug applications or filing processes that exist in the US, the Europe, Australia, Japan, and how it compares with your rules and regulations in India. So that's something that we can always do to help ourselves to further our careers within the industry.
All right. Thank you so much, Dr. Kirtan, for being with us today and addressing to all the questions which are coming across so patiently. Thank you so much, student, for those amazing questions. Thanks a lot, Doc, for being here for an excellent presentation. And with that, let us now move forward with our last but not the least session, and which is practical practice change at scale. And for that, we have with us Dr. Aswani Saha, International Medical Director for Lung Cancer. Dr. Aswani is a distinguished professional with a wealth of experience in healthcare and pharmaceutical industry. Currently, Dr. Aswani is serving as International Medical Director for Lung Cancer at AstraZeneca, and Dr. Aswani brings a comprehensive background in medical affairs, regulatory affairs, and vaccine development. Over the past years, Dr. Aswani has played pivotal role as Country Medical Affairs Director and Asia Area CVM lead at AstraZeneca, demonstrating leadership and expertise in dynamic field of medical affairs. And this includes an interim position as Asia Area Medical Director as well. With that, let me now hand over the forum to Dr. Aswani Saha for taking it forward. Ma'am, over to you.
Thank you so much, Ashish. A very good evening from me. I understand it's 4:30 there. So a very good evening, and thank you so much for the kind introduction. So just to give you a quick brief, a little bit more of what from Ashish said. So I am from Malaysia, residing in Malaysia. As you know, I was the previously, as of November, the Malaysian Medical Director. And as of 1st December, I've now moved to international role in oncology under lung cancer, but also still based out of Malaysia. So that's just a little bit about me. Today, I'll be talking to you about practice change at scale. Ashish, how do I'll share my screen from my end?
Yes,
Okay.
yes, yeah, you can.
Okay, can you guys see my screen?
Yes, it's visible.
Okay, so what I've coined it as is basically transforming healthcare paradigms as ecosystem engineers. And why this is important is because I think somewhere down the road, when we decided to be medical professionals or medical doctors, what we wanted to do was make a difference in someone's lives, right? In some way or other, whether it's in a small scale or at a large scale. And over the next few slides, I will tell you how we as medical professionals in pharmaceutical industry can also make huge paradigm shifts and huge changes to patients' lives through the amazing work that we do. So what is practice change at scale? Let me draw it back a little bit for you. So I will bucket it into the 3 pillars here. So what is happening now is it's unprecedented times, right? Where in 2023, we've just overcome one huge pandemic, which has been a huge learning and humbling experience, I think, for all of us. We have unlearned and relearned so many basic things of just how to be in one small confined space, how the healthcare paradigm is stretched beyond its means to support. And I think we all came out of this stronger. Now, in this unprecedented times, right, what are some of the key things to highlight to you? Number one, there's definitely a growing healthcare burden. You saw COVID happen, you saw COVID continue to happen, and 71% of global death is attributed to non-communicable diseases as well. I don't have to tell you what are the huge paradigms in terms of non-communicable diseases such as cardiovascular, cancer, COPD, diabetes, which basically is calling for action and needs urgent interventions to be a part of our treatment for patients. The second one is, as a pharmaceutical industry, the expectation has become a lot more for us to step up. So post-COVID, I think in COVID times, how we stepped up and what kind of role we played has now changed the dynamics of how pharmaceutical companies partner with the government, Ministry of Health, to bring about huge transformative changes for patients, right? So the expectation has definitely stepped up a lot more. 71% of the public believes that health companies must build confidence in the health ecosystem in order to earn trust. There's an expectation to delivering patient outcomes through holistic care offering that goes beyond medicine. And medical is the preferred healthcare partner. So medical has a huge value to play with HCPs in terms of interaction. So hence the value of medical in pharmaceutical has also stepped up and has also changed. We're not only the ones who speak about the science, but we also go beyond to provide an ecosystem approach change to how we partner with the governments and to improve healthcare for patients. Now, how do we do this, right? With this growing healthcare burden, the expectation changing, what is practice change leadership? It's basically, number one, our unique portfolio of innovative medicine. We have to leverage on that to bring about the best form of treatments for patients. So that's the first one. The second one is going beyond science and brands to a true healthcare system partnership and practice change leadership. So what this means is we're not talking about one medicine which is going to help a patient. We're talking about the overall ecosystem that we're going to build. And I'll give you an example later. So for example, in lung cancer, how do we screen patients early, diagnose them early, and then, ensure that they get the right form of diagnostic tools to ensure that, which is the mutations that are occurring, and then give them the right form of treatment. What will this help? This will inevitably help patients have more longevity of life, right? Families have more time with their loved ones. And that in essence itself is all of us changing and transforming healthcare at large and at scale. Practice change capabilities is very, very important whereby we need expertise in driving transformation in health systems through real-world evidence, solution portfolios, and supporting population health management. So what are the measures of success in practice change at scale, right? Or this ecosystem transformation? So how do we measure it? How do I say, or how do I sleep at night knowing that I've done what I call practice change at scale? So these are the 4 things. Number 1, guidelines, leadership, and adaptation. So ensure that we change guidelines to improve patient care, whether in any genre, right? Whether in oncology, diabetes, cardiovascular, any genre, to ensure that patients are getting screened early, treated early, and treatment is optimized early, and hence they have a good quality of life. So guidelines, leadership, adaptation is extremely important. The second one is proactive patient identification. What does this mean? It means supporting the healthcare system to identify or diagnose high-risk patients through medical record platforms and targeting precise diagnostics. So proactive patient identification is actually building an early screening modality into your healthcare, right? So whether you go by state-wise approach, you go by city-wise approach, or you go by a few centers in one municipal or city or something, where you say, okay, I'm going to start early screening for diabetic patients, or I do early screening for lung cancer patients through X-ray and AI. So those are proactive patient identifications. The third one is pathway redesign. So this is when pathway optimization is in priority accounts to ensure the right patients are referred and followed up. So basically, like when we say, like, okay, we have diabetic patients. Now, how do we identify patients with diabetes and heart failure, whether it's ejection fraction reduced or ejection fraction preserved heart failure? So how do we do that? So those pathways in identifying and screening the patient early to the patient receiving treatment early, creating those pathway redesigns and enhancing those pathways within our public and private hospitals is another way to ensure that we have sustainable change within the healthcare system. And last but not least is world-class policies. So policies are the ultimate goal, right? We can do small hospital city pockets, but that is just so much that we are helping to change. If we can change an entire policy for a country to ensure that people above 40, whether they're smokers or non-smokers, are screened for lung cancer. Okay, maybe 40 is too ambitious. People above 50, right, whether they're smokers or non-smokers, are screened for lung cancer through a chest X-ray with AI. That is something which is world-class policy shaping, because that will then shift your paradigm of lung cancer detection from stage 3, stage 4, which is 80% of the lung cancers which are screened, to stage 1, stage 2. So a little bit more about the ecosystem approach, right? So what does ecosystem approach mean? It means that we not only focus on the treatment for the patients, but we focus on building awareness and prevention. We focus on diagnosis, so early diagnostic, like what I've been talking about in terms of lung cancer screening. And then we ensure that the right treatment goes for the patient. And then post that, how are the patients going to be monitored? So this is where medical plays a huge role in bringing about this whole ecosystem approach to ensure that we have covered every single angle when we have an innovative medicine in play in the system. And ultimately, all of this then, together with your corporate affairs team, will lead to policy change, which will shape and change the policies of a country and then ensure that the people are getting the best and optimal care. So last but not least, here are some key examples on how we have access to healthcare in action. So one example I would like to share is in terms of equitable access through a Catalyst network. So we have a Catalyst network, which we have about 20 hubs across globally from AstraZeneca across the world. And what these networks do is, so as a network, for example, or a hub, so if I give you Malaysia, for example, as a hub, we have solutions that we bring into the country from different parts of the world. So we have Cure-I, which is from India. We have, iDetect for COPD. We have different solutions that we bring to enhance early screening. And then we also form a platform for local companies and startups to come and pitch their ideas in terms of what are the new ideas they have that they can bring together and bring forward in terms of transforming healthcare for patients. So if, let's say, a startup pitches a great idea, we will then bring it to our international platform where they will pitch their idea, and then we can see how we can partner with them to engage and see if this system can then, help optimize and make our healthcare systems better in whichever countries that we want to initiate this in. So that's one example. The second example is, as I've mentioned earlier, is lung screening for early screening for lung cancer. So we're partnering with a company called Cure-I, and then we partner with local healthcare organizations. So we form a tripartite and a partnership approach for a project called Lung Ambition Alliance. And what this is basically incorporating AI into chest x-rays and putting them in primary care centers to screen early for incidental pulmonary nodules, which then so what the naked eye can't pick up and where centers are overwhelmed, this system is put into place, and the AI will read the chest x-ray, and if it picks up an incidental pulmonary nodule, we will then risk stratify that patient. Is this patient number 45, with a family history of lung cancer, smoking, etc. So we'll stratify the risk factors, and then if this patient is eligible, we will send that patient in for low-dose CT scan to ensure and check if that is lung cancer or not. So these are modalities which we are bringing about, not just one or two pilots in one or two centers, but at scale. So we're doing it by state, we're doing it by city, we're trying to bring it into shaping the policies as well. We're bringing it into private as well as public partnerships. Last but not least is also building the health system resilience through partnerships of health system sustainability resilience, which help governments give practical solutions to make health systems more resilient and sustainable. So this is a partnership which we do through corporate affairs with the government to build together a plan to ensure that the health systems are resilient and sustainable. So in a nutshell, practice change at scale is something which is extremely important in 2023. And medical as a function in pharmaceutical plays a key and pertinent role in bringing this forward and taking this into shape in every single country. And it's not something that should be small, but it should be something that's scaled up to a larger scale, that it should shape policy for a country over the next 2 to 3 years in whatever scale that we do. And ultimately, will it make an impact for patients? Yes. Will it make an impact in transforming the healthcare systems in all the countries in international, which are developing countries, right? Astounding, yes. So that is what practice change at scale is. And that is something that we do on a daily basis that hopefully makes us proud of the work that we do and brings us to work every day and gives us a purpose in the work that we do. So with that, I leave you with this. It's my favorite quote. And I always believe that leaders don't create followers, they create more leaders. And as leaders, we're all leaders, right? Because the person that's leading is not a leader. Every single person is a leader because we're all making changes to the world in one way or other. And as a leader, remember to have a small ego, an open mind, a humble heart, and a belief of more talent is around the corner, and a purpose greater than yourself. And what more, a purpose like practice change. So with that, I thank you, and I hand it back to you, Ashish.
Thank you so much, Dr. Asani, for being there with us today and for explaining and steering this interesting topic to the students. Thanks a lot for that. We do have, some questions which we received from the students. My first question to you is, what collaboration models or frameworks do you find most effective in bringing together diverse stakeholders under healthcare ecosystem to bridge identified gaps and drive positive change for the patients?
Okay, so what collaborative model you're talking about, right?
Yeah, or frameworks, or yeah.
Yeah, so I think internally we do have our frameworks and models, and there I'm sure that every organization has their frameworks and models. But essentially, I think what part of the framework, right? Number one is we need to identify what is the health care priority in the system. So if you take Malaysia, for example, so I give you a Malaysian example because I'm most familiar with it, right? Malaysia, for example, what is the burning need in the healthcare system is early screening, because our accident and emergencies are overwhelmed, our tertiary hospitals are overwhelmed. So we need to bring medicine to primary care. So identify what is the healthcare priority, that's one. The second one, I would say, in terms of the framework, is to then crystallize what is the priority accounts that you want to work with. So who are the people you want to work with, right? And again, if I say, okay, I'm going to work with, one state in Malaysia or in India, one state that I'm going to work with, who are the stakeholders I'm going to work with? And if I'm going to go to Ashish and he's one of my stakeholders, I'm going to say, and he's saying, no, I'm not interested. The perseverance and the courage to open other doors should be there. So when you've identified that stakeholder and that stakeholder says no, or the stakeholders say yes, but goes in a different direction, always come back to ground zero, right? So one is healthcare priorities. The second one is basically identifying the right stakeholders and working with them. Then you go into the actionables, right? The right solution, as well as the right people involved. And you need to constantly have that buy-in from the people externally and internally. So internally as well, it shouldn't be just one team leading it, right? It should be the entire cross-functional team supporting each other. Externally as well, there should be a buy-in from the individuals externally in the government that they want to make this change together with you. And then you bring the solution. And then you always have to have the last framework is the impact. So how do you measure what are the impacts that you're going to create at one juncture? At 1 year, we're going to do this. At 2 years, we're going to do this. But if I'm going to do this at 1 year, I need to check every 3 months. So I need to sit together with my external stakeholder and chat every 3 months on what are some of the areas that are working and what are not working. So that's a very long answer to a short question, but I hope that answers your question.
Thank you so much, Dr. Ashwini. So my next question to you is, what are your views in terms of integrating technology, which is coming nowadays, to help identify and bridge the gaps that could actually, help significantly to the patients? So I think the question is around, your inputs in terms of using technology around practice change at scale.
Oh my God, I think that's the best thing ever. So there's a lot of great technology these days, AI, for example, right? So there's a lot of AI-based technology that we're using. So a few things. So for example, AI is one of it. So we're using AI to read, you have AIs to read chest x-rays now, AI to read echo. They're not taking away the role of individuals such as radiologists, but they're just helping them. They can't be reading 2,000 x-rays in a primary care center, right? Nobody's capable of doing that 2,000 x-rays a day. So that AI is actually aiding and helping us to actually make our lives simpler, so they can then focus on the next steps of reading that low-dose CT scan, for example. So technology is definitely most welcome. There's a lot of good technology, but I think we need to ensure that there's a lot of people trying a lot of different things, right? So validation is extremely important, and ensuring that the sensitivity, specificity of that technology has been tested before we put it into proof. We can't believe in something and then just work on it out of belief. There should be some evidence base to it, but if there is clear evidence base to it, it definitely is extremely helpful especially in pushing the healthcare system towards primary care and towards identifying diseases early and treating them early.
Right. Thank you so much, Dr. Asim. My last question to you is around sustainability. And the question is, how can healthcare stakeholders ensure sustainability of the solutions which is there in place?
Okay, so sustainability is a very good question, right? And actually, sustainability is two things. One is, as I first mentioned, we have to make sure that we have the right part. So the right, what is the right vision and strategy that we have, right? So what do we want to do? And what is the government or the society that you're doing it with, is it in line? So the right ambition needs to be there. The second one is we have to ensure that we have the right partners. Everybody's equally invested. Everybody wants the same thing. That means everybody wants to see a stage shift in lung cancer from stage 3, stage 4 to stage 1, stage 2, as an example. That's a second. The third thing is then we have to find a model where we can catalyze the system now. So we come into the system, we provide, let's say, for example, chest x-rays with AI, 1, 2, 3 years. And then that system should be then able to sustain itself and run. And that is how we measure sustainability. And how that is done is we need to have very clear goals in terms of year 1, we're going to do this. Year 2, we're going to do this. Year 3, we're going to have a publication on this and present it to the government and ensure we, have this as part of policy by year 4. Then in year 4, it will be, or year 5, hopefully it's up in the policy and it's part of, national policy or state policy. And then what happens is sustainability automatically happens.
Right. Thank you so much, Dr. Ashani, for being with us today and for an excellent session around practice change at scale. I'm sure that this particular session must have tickled some young minds who are listening to us today, and they would start thinking around connecting the dots that are there that needs addressal in healthcare ecosystem. Thank you so much for being with us today, Dr. Ashwani.
Thank you, everyone. Thank you, Ashish. Have a good evening. Bye.
You too. With that, I think let us call it a day and stay tuned for day 4, which is 16th of December. We do have certain important sessions planned on 16th of December, including power of networking, then how to prepare ourselves for the interviews that are there in place. And we would also have a live session from the interns who joined us last year, and they would share their stories around their experience which they had. And with that, I would also like to thank all the students for the patient hearing and staying with us till the end of the event. And I would also like to thank all our speakers for today. And finally, I would like to thank all our partners, CHES, KEM Hospital and Medical College and KEM Hospital, Mumbai. And I would like to thank Dr. Sandhya Kamath ma'am, Dr. Rakhi ma'am for being here with us today. Thank you so much.